Hey everyone, Dr. Shahid here, and in this video, we're going to talk all about the surgical components of endodontics. Most people don't actually associate the specialty of endodontics with surgical procedures, but the reality is, when our traditional endodontic treatment doesn't quite hit the mark and fails, we're faced with two options, each tailored to the specific nature of the problem at hand. So the first is endodontic retreatment. This is a non-surgical approach, and it's essentially just a second attempt at the root canal treatment. Picture this as our second chance, where we meticulously re-navigate the canals, seeking out any elusive bacteria or overlooked canal spaces that might have sparked the issue of reinfection. Our second option is endodontic surgery. This surgical route is our go-to when the problem lies in areas inaccessible through conventional root canal treatment. Think of this as a tactical mission where we surgically access the root tip and directly treat the problematic area. Both of these strategies, endodontic retreatment and endodontic surgery, are crucial tools in our arsenal, but how do we know when to actually take the surgical route? In other words, what are the indications for surgical endodontics? Well, our first one is a persistent or enlarging apical pathosis after non-surgical endodontic treatment. So essentially, I'm just talking about those stubborn apical pathoses that refuse to shrink or disappear even after a well-executed non-surgical endodontic treatment. Our second indication is when the non-surgical approach isn't feasible, because you have to remember, when you retreat a tooth, you're removing the obturation materials and re-cleaning and shaping the canals, which inevitably means you widen the canals, which further weakens the tooth. So sometimes the non-surgical approach isn't the best way to go. So in the radiographs shown, we're able to see that the surgical removal of the periradicular lesion that failed to respond to initial endodontic treatment can lead to a very successful outcome when the procedure is carried out to a high technical standard. Conversely, we should also know when to steer clear of surgical endodontics, or in other words, the contraindications. The first obvious one is anatomical factors. Examples of this would be a thick external oblique ridge or a neurovascular bundle lying precariously close to the root apex. These are no-go zones for surgical interventions. The second is medical or systemic complications. In these situations, the surgery itself can have risks that outweigh the benefit of treating the tooth. An example of this would be if there is a high risk of osteonecrosis following surgery, or if the patient has another illness that makes a surgical approach unsafe. Our last contraindication is another obvious one, but it's when the tooth itself is non-restorable, or if the surgery will render a poor prognosis. Okay, so let's say you have a root canal treated tooth that has a poor crown to root ratio and needs to be treated again. Well, you can imagine that taking a surgical approach would worsen the crown to root ratio, which worsens the prognosis. Another example shown here on the radiograph is a case where we actually have a vertical root fracture as denoted by the J-shaped radiolucency. Obviously, a surgical approach in this case would also be contraindicated as the tooth is considered not restorable. Okay guys, with all of that out of the way, let's actually talk about a few different surgical endodontic procedures. We have incision and drainage, trephination, and finally periapical surgery. Let's begin by looking at incision and drainage. Picture a scenario where we're confronted with a localized, fluctuant swollen area. This is a classic sign of an underlying abscess or infection. In a case like this, drainage isn't just beneficial, it's essential. We make a precise incision to effectively facilitate draining of the exudate, which provides immediate relief from pain and pressure. This is often the first line of defense against acute infections, but sometimes it's not enough to just cut through the soft tissue. Sometimes we need something more, and that's where trephination can come in handy. Trephination can be thought of as creating a large vent hole in the bony housing. So in this procedure, we carefully drill a small hole through the bone to alleviate pressure in the area of infection. So this technique is particularly beneficial in cases of severe swelling or when we need to quickly reduce pain and pressure. The last and most intensive procedure is periapical surgery itself, otherwise known as apicoectomy. This procedure involves the removal of the apical portion of the root along with any surrounding infected tissue, which gives us access to the obturated canal. So periapical surgery is pretty intensive, guys, so it's worth discussing it in greater detail. Okay, the first step of periapical surgery is administration of anesthesia, followed by a soft tissue flap to expose the bone beneath, a crucial step for clear access. Okay, so after our flap is raised, we drill through the bone to reach the tooth apex. This step is essentially trephination, but the drilled opening is much larger since we need complete visualization of the tooth apex and the surrounding bone. Next, we have the apicoectomy procedure itself, which again is just the removal of the apical portion of the tooth, typically 3 millimeters worth. And we also remove any infected tissue surrounding the root as well. So once this is done, we use an ultrasonic instrument to prepare the last 3 millimeters of the canal from the root end before filling the root end with MTA. Finally, we suture the soft tissue flap and allow time for the bone to heal. Alright guys, that's surgical endodontics in a nutshell. Now let's reinforce everything we just learned with a couple practice problems. We have a 50-year-old male with a chief complaint of swollen gums and a tooth hurting while eating. Background on our patient history reveals a previous root canal treatment and some restorations. Current findings indicate a localized fluctuant swelling associated with the endodontically treated lower right first molar, which is painful on percussion. Okay, so the question is, what is the appropriate treatment option of the lower right first molar? And we have a radiograph provided as well. Pause the video, and the answer is C, extraction. Remember guys, endodontic treatment is not always the option. We have to diagnose the tooth correctly before embarking on a treatment plan. In this case, we have a vertical root fracture as denoted by the J-shaped radial lucency. So it's a contraindication to initiate endodontic treatment. This tooth is hopeless, therefore extraction is the best option. Alright, let's go to the next question. Which is the most appropriate tool for retrograde cavity preparation in endodontic apical surgery? Pause the video if you need, and the answer is ultrasonic tip. This was a gimme question. If you guys missed this one, go back and watch the video because you missed some important information. The ultrasonic tip is the most appropriate instrument for retrograde cavity preparation. Alright guys, that's it for this video. Thanks for watching. See you next time.